Hey, my name's Nick. I'm a paramedic with very low exposure and experience in maternal birthing complications, but this will be offset by Alice.
I'm a midwife. I've been working for over 10 years and do have a lot more experience in terms of birth complications.
It's not hard. I set the bar. Down here. The purpose of this brief video is to just visually demonstrate the manoeuvres, techniques involved in breech and shoulder dystocia. The CPGs are great and we're going to be following those, but they're very text oriented. So it's just a refresher. We've all done this before, but just to see what it looks like should we face this clinically. Acknowledge that these maternity mannequins are hard to come by around South Melbourne. And if nothing else, it's an easy few minutes of CPD should APRA order you. Alright, so we'll start with breech, Alice.
Yep.
Now, I don't know much. My understanding is I'd be hauling Piper and then hands off breech is what's going to be going through my head. If you were in the birthing suites and you had an unexpected but imminent breech coming, what's going through your head as principles?
For me, I'm thinking ahead and I'm thinking that a baby who's born via a vaginal breech birth is more likely to have recess. So that's probably where my head is at rather than worried about the actual birth.
Yeah.
It's not really well documented in the CPG, but these births, the actual diameters of the head and the baby, these actually progress better in an all-fours position.
Okay.
So the CPG, the manoeuvres are discussed in a sit-in or like a supine position. But if your baby's coming and it's coming well, actually the easiest way to be hands off is to flip your patient over to be kneeling to all fours.
Yeah, yeah.
But for the sake of this mannequin, it doesn't have great knees, so we will do it in a supine position.
Love it. And my understanding is like all the mechanics, the physics are the same, be them supine or all fours, but it's just kind of like looking at a map upside down. You just change your mental orientation.
Yep.
Great. Okay. So there's a few different types of breech, the way that it can come out.
Yep.
What's the scariest?
A foot-lean breech or a knee. Neither of those have got a nice, neat, round presenting part, so it doesn't match the size of the cervix.
Yeah.
Has increased complications of things like cord prolapse and other things like that. And in terms of like the efficiency of the labour, that will be increased if you have a frank breech. So you have either the feet up by the head, or if you've got a complete breech and the feet are tucked in front of the body, because then you've got a nice circular bum pushing on the cervix, and that feeds back to the brain a lot better that things need to continue on.
Okay. And how do they commonly present?
Often just like a foot comes out or 2 feet come out. The other really key sign would be that you would have fresh meconium before you even saw the presenting part. If you ever saw like Vegemite or toothpaste, like black toothpaste come out, that would be a major red flag that it doesn't come out in that form if the bum is up here. By then it's been mixed with the liquor and it's going to come out like green and watery. But if it's coming out fresh, then that's your big key sign that you've got an imminent breech birth.
And a sign of distress.
Well, in this case, yes, distress, but also just a sign that the birth's getting closer because the guts are getting squeezed.
Yeah. Good to know.
Yeah.
Good to know. All right, and when it's coming out, there's obviously, it's coming out legs first, but it can also be facing kind of the mother's spine or upright. Which way do we want it?
So we always want, if our mum is positioned like this, we want the back to be uppermost. So we've got 2 like golden rules for a breech birth. So if you make sure that the back is uppermost and that we're not touching it as much as possible, then you should have a great breech birth.
Great. All right. Well, that's
the 2 main things you need to remember.
Let's demonstrate that. Would we get mum to try and get her hips towards the edge?
Yeah, so for our own convenience, absolutely.
Yeah.
And just in terms of people being able to see, we might just put the legs up.
Yeah. Very obliging. Okay. So I'll push.
You can be the mum, great, perfect.
Yeah. Feel more comfortable doing that. And I won't tell you which way the baby's facing, but we'd be reassuring the mum, obviously.
Yeah.
And you've recognised that it's breech.
Perfect. I'm still supporting that perineum. Try not to touch baby. You need to be a bit stronger.
I need to be a lot stronger. This is
You're almost there.
Yeah. Trying real hard. Some reassurance would go a long way right now. Yeah.
Alright, so our baby's coming and you can see that our back is not uppermost, it's over to the side. So it's going to be really hard for me to manually rotate it with only this little bit of the bum out. So I want to wait for baby to come down a little bit further.
So further contractions, mum's pushing.
Perfect, and I can see the knees now, so I should actually have enough of baby to hold on to. I'm going to make sure I'm only putting my fingers on baby's sacral dimples and this baby's got rather hard tissue, but otherwise it's going to be in the groin, and I'm just going to really gently rotate baby back to uppermost.
Yeah.
And then I can take my hands off again. Normally, these feet will probably spontaneously birth. If they didn't, or we're having a really slow birth, you can see that our umbilical cord is already out. So at this point, I want my baby to be born as soon as possible. So I'm just going to put my fingers behind the knees and help those feet to slip out. We've got one hand that's spontaneously birthed. If the other arm is above the head, it won't. And we'll need to rotate it, holding it in the exact same position. Up higher.
Amazing. And I'm noticing you're using the pelvis there again, not the abdomen. Yeah.
And using my fingers like really quite down low. And I'm going back uppermost again, and then I'm letting go. It's actually easier. If you're right up in there, it's really hard not to touch. Like everything makes you want to touch. So if you can sit down or kneel or like physically move yourself back, it actually is really helpful. Then I want to wait until I can see the nape of the neck. We're almost there, but I'll probably get my mum to push one more time.
Yeah.
And at that point, I'm going to let the weight of the baby hang on my forearm. And I'm going to get my fingers inside. And this is going to be uncomfortable. So I have to be letting my patient know what I'm doing and why I'm doing it. And I'm letting the fingers sit on the cheekbones. So as the baby is birthed, so I'm going to say like a big push at this point.
Yeah.
I'm going to stand up and put a little bit of pressure on the back of the head so that I'm bringing my baby's head out in a really nice flex position. You can see that my fingers are there, and the baby's going to come up onto the tummy.
Amazing. You made it look so easy. But my real takeaways from that was get back uppermost if we're in this position. We flip it mentally if the mother's on all fours. We're hands off as much as we can, but we use the pelvis to gently rotate and go leg, leg, arm, leg.
And every time you touch, just make sure you stop touching again, because if you need to bring it back uppermost, that's when people then tend to keep their hands there or keep fiddling. So every time, just a mental note, I'll do it and then put my hands back.
It'll be a hard mental thing to come across on it, like.
And you're so full of adrenaline, like you want to do something. It's like it's a pretty natural response, but we need to try and stimulate as little as possible.
Yeah. Love it. Thank you. All right, let's go through shoulder dystocia.
Great.
Very scary.
Definitely.
Yeah, and we all will have just done the CPD for 2024, which is a lot of the neonatal resuscitation. So we're not going through that today, but acknowledging both breech and shoulder dystocia are going to bring about that likelihood. So.
Another good thing is to think that in maternity things come in threes. So if you have a shoulder dystocia, you'll probably have a neonatal resus, and that in itself disrupts the normal hormones that your mum is going to be feeling. So she'll be full of adrenaline, and then she'll have a postpartum hemorrhage. So it's one after the other, but you need to kind of be a step ahead so that you have at least got everything ready to make it a little bit less stressful when you're managing it.
And you like being midwife?
Love it.
Yeah. Could not do it. All right, so as we know, with shoulder dystocia, it's a mechanical obstruction between one of the shoulders with the pubic symphysis. And we've got 7 minutes is the textbook, but as soon as possible. So it's a very manual undertaking. How many people do you want to start doing this at a minimum?
Like 4?
4, yeah.
So if there's only 2 people on scene, you're going to be hard pressed and you're going to have to get bystanders or think about how you can be creative with it.
I think it's important to talk that through because, we largely operate in crews of 2, but particularly for the McRoberts, I learned from you, it's not just a passive undertaking, one leg, it's 2 people back forcefully,
So let's put our legs back actually so that we can do that properly.
Great. Well, do you mind demonstrating
I'd
again?
love to,
So, we'll talk through, the heads come out as per normal birth, and we wait for it to restitute.
And it might be a bit hard to see, but currently it's like eyebrows to the perineum. And that's actually a really classic, can you see that? I don't know if you can look that up. That's actually a really classic sign of once, normally the head will just slip out once you get to this point. But if it's really hard work to get the whole face out, you might need to like sweep the perineum off the face. Can you push the baby through a tiny bit more? Then that's already like a bit of a red flag that potentially it's not coming out as fast as what it could.
That's really good to see because we talk lots about turtle sign. But then
so like the predecessor with that would be like you can see the forehead, you can see the eyebrows, and it's like so much effort to see every anatomical landmark of the face. And then it just kind of gets stuck at the chin.
So if there's a hold up at this point where
you're thinking
freaking
about
out further.
Yeah, you think about whipping the pillow out and stuff like that before you even have your shoulder dystocia.
Oh,
so you've already like created a situation where you can get your patient flat before you've even declared it.
Yeah.
So your turtling is really obvious if you yank your baby back.
Yeah, it's really a physical undertaking.
So it actually looks like that. That's perfect.
Yeah, okay.
So, and you can't miss it. If you're looking at the head at that moment, you will know it's turtling and you'll be like, oh, it actually looks like a turtle's head going back into the shell.
Yeah.
So it's the best descriptor and that is what it looks like. So as soon as you see that, you're trying to get into action stations and do everything that you can. First of that would be actually declaring it. I think we're having a shoulder dystocia or I'm worried about the shoulders, however you want to say it. For me, the first thing I would do is make sure that I can get my patient completely flat.
Yep.
So if they're on like a couch or something like that, you'll probably have to physically get them up and get them on the ground.
Oh, okay. So the couch, bed, no good.
Bed, fine if you can get them flat,
Yeah.
but if there's not enough room on the couch for them to go lay completely flat on it, they either might need to turn around or get off it completely.
Okay.
But you want them on a surface where they can be completely flat. So if they're in a bed, at that point of being at the eyebrows, we would be pulling out pillows, anything behind them so that you can get them back and get them flat.
Which is critical for the upcoming McRoberts.
Yeah.
Yeah. All right. So we've declared, we're concerned. By this stage, we've got other resources coming for help. Team of 4 is ideal.
Perfect.
And resus station set up.
Great.
How are we overcoming it? We'll tell mum our concerns.
Yep.
Yep.
And in really plain language, I'm worried your baby might be stuck.
Yep.
I need you to do a few different manoeuvres so that we can get your baby out. At that, a patient who hasn't moved for 4 hours will jump up and do everything that you need them to do. They're full of adrenaline.
Okay.
So a good McRoberts, in this setup, we can't do it.
No.
We need 2 people on each. Our baby's just falling out.
Yeah, well, you've solved it. Well done.
Fix it. We need to bring our knees up to the patient's nipples and in a completely flat position, and they have to go at the same time and be really flex.
Yep.
So we'll go on 1, 2, 3.
Yep.
And we actually need to hold them in that position to maintain a good McRoberts. And so it's like you're actively, either the foot or the knee, but you're actively holding it there.
Pushing down, yeah. It sounds so cruel, like mum's already going through so much. She's got this huge abdomen mass.
Yeah.
The tendency will be for her to be in the position of comfort with them down, so you do have to be cruel to be kind.
Yeah. And then we need to see if it's worked, which is where we need a third person.
Okay.
Because you can do a McRoberts, but our baby's just sitting here at this point.
Yeah.
So ideally we've got someone else on this leg. And with that McRoberts, I want to put a little bit of traction on to see if the shoulder has slipped under the pubic arch.
And I can see you putting traction downwards.
So I'm doing it in line with baby's spine. So we call that axial traction. What you want to avoid is pulling the head. These babies don't have great range of movement, but pulling the head like that. So that's going to increase your chance of a brachial plexus injury. So I'm pulling it down in the direction that the baby is lying, rather than down towards the anus or down towards the bed. That would be like that.
Yeah, understood.
But you need to, if you're going to do McRoberts, you need to actually check whether it's worked or not.
Okay.
And then if it hadn't worked, we would then be going into suprapubic pressure, which we're going to do from the side of the baby's back. This baby's been really obvious for us and it's facing that way.
But if it was more, withdrawn.
Yeah, and if it was really sometimes they don't really restitute, so it's really hard to know in that position which side of the back is on. You could either do it from both sides, that would be one solution, or you could just pop a finger in and actually feel for your baby's shoulders and feel from it that way. Either way is fine.
Or look for the anatomical landmarks, ears, face.
Yeah.
Yeah.
So if our baby's on this side, then we're going to be doing suprapubic pressure just above the pubic symphysis. And you can ask your patient, especially if they've got a bigger BMI, it can be really hard. You want to go just above it. So ask them where it is and then put your hands right behind it.
Yeah.
And CPR position, quite firm. If you can get up onto the bed, if they're on the bed, that's going to be better.
Just more body weight down you can get on.
Yeah. And you have to be pretty firm because you're actually trying to push through the soft tissue to manually push the shoulder in that direction. So if a little bit of pressure is not going to do anything.
And in the real world, there'd be someone here as well.
Correct.
Yeah.
So we start off just with flat pressure and you can do that for about 30 seconds. And then you can go on to a rocking motion. Again, just trying to sweep that shoulder under the symphysis pubis. And at the same time as doing that, you've got someone again doing that gentle traction.
Axial traction.
To see if the baby's swept under.
Amazing. So I know with our CPGs by the textbook, it's 30 seconds in the McRoberts, the knees to nipples, and then the suprapubic pressure and then rocking. In reality, we're moving through it quite quickly, aren't we? It will happen
And you're full of adrenaline, 10 seconds or so at each one. If it doesn't work, it doesn't work, move on to the next thing.
Yeah, yeah.
But to be doing this properly with suprapubic pressure, we're at our 4 people now. We've got someone on each leg.
Yep.
We've got someone doing pressure and someone trying to birth the baby.
Mm-hmm.
If you had 3 people, it's not ideal from an OHS position, but you could jam a leg up onto your hip or something and be giving pressure at the same time. If you're in really low resources, that's what you'd have to think
It's
about.
often cited, we're not, best practice, it's least worst that
Yep.
we employ. So you
Yep.
work with what you have at the time.
Yep.
But should all of that be unsuccessful, what are we thinking? Are we going to try and get mum to roll?
Absolutely.
Yeah.
If this is like a terrible analogy, but if you think of getting a cork out of a bottle of wine, you don't just pull it out, like you go side to side.
Yeah, yeah.
Like, it's just the movement to actually get it out. It's the same kind of thing. So sometimes even just the action of rolling over is enough to change that diameter of the pelvis to then let the shoulders come underneath.
Yeah.
But it also in all fours, it's a bit hard to show with this mannequin, but it's a really exaggerated McRoberts.
Yeah.
It's exactly the same. So they can't be sort of kneeling on all fours. They still need to be in that knee to nipple position, just flipped over.
Yeah, and that's probably a good one to highlight because it says Gaskins or all fours, but it's really an inverted McRoberts, isn't it?
Yeah.
I will overlay an image for
perfect.
clarity there. Amazing. Alice, I think we've gone through everything we need to. That's really, really helpful. Anything else you want to add or...?
No, just I think the only thing to remember is that these are like the absolute rarity. You can go to every birth, set up your resus equipment, have your drugs out for a PPH, but it'll probably just be a beautiful normal birth.
Yeah, good. That's a good note to end on. Thank
It
you.
will be.